I'm very proud to be recognized with this award. I have to tell you that when you stand with the giants like Bob Pinedo, and here you see some of one of his modest accomplishments looking at the metric of papers and chapters, it's quite humbling. And I have to tell you that when I was a second-year fellow, I wrote my first book chapter, and it happened to be in the book Cancer Chemotherapy Update 1984 by guess who? The editors were Pinedo and Chabner. And so you know as a fellow or as a trainee that when you do something like that, you stand in great reverence of the individuals who are the guys with their names on the front of the book or with their names in the editorial column of the journal. So I was in great reverence of these individuals. The co-author on that, Fred Smith, was in charge of the fellowship program at Lombardi, and he's pictured here. To even be included in the same sentence with these individuals, much less on the same podium, is a source of great satisfaction to me. I thank Marty for his very eloquent discussion this morning. I don't know how he had time to go to Ireland and kiss the Blarney Stone on his way to the lecture, but he always manages to come up with a little bit of hyperbole, which we all appreciate. Here's actually a picture of the book. It wasn't available online because there was no such thing as online back in 1984. And so it really is a great source of satisfaction to me to be here. I would also say that whatever my accomplishments are, they have always been supported by my wife, Linda, who has the check. And I very much appreciate what she's done for me over the years, being a traveling companion and an intellectual companion during that time. Obviously, mentoring is something that's very important to us as people in medicine, as leaders in our fields, and as trainees. And I wanted to make this quote that came from Steven Spielberg: "The delicate balance of mentoring someone is not creating them in your own image, but giving them the opportunity to create themselves." And I have to thank Bob and Bruce and Fred and many others for providing that to me, and I hope I'm providing that to others. Now, it's interesting, we're talking a lot about genomics. We're also talking a little bit about genetics today. We want to be making sure that we're making observations of similarities and differences that lead us in ways. I'm going to ask you to determine whether you think that there's any resemblance here between the man speaking on mentorship and the man speaking before you. As far as we know, we're not genetically related, but maybe we should have our genomes tested and see. So with that, I'm going to start my talk, which is on genomic profiling in GI cancer. Are we ready to use these data to make treatment decisions? And this is a practical approach to what we're talking about. Here are my conflicts of interest, if you believe they're conflicts. And I'm going to start out talking about gastric cancer and then turn to the area where I do most of my research, which is colorectal cancer. Now, back when I was a fellow, Jack McDonald, Phil Shine, Paul Woolley, and Fred Smith published this paper in the Annals of Internal Medicine, which was a very important finding at that time because gastric cancer was such an awful disease with such a poor outcome. It was a phase 2 study, 62 patients, showed a 42% response rate with 5-FU-Adria and mitomycin. Combination therapy for advanced gastric cancer. And it was so noticeable that it was on the podium at ASCO and really was something that put Georgetown on the map as a GI cancer center. As time went on, there were additional studies that were done with other chemotherapy agents. Here's an example of a study by Eric Van Kutsum, much larger randomized phase 3 study. Instead of 5.5 months median survival, got up to 9 months median survival. And then the next example, a study by Waddell, actually used a targeted agent, panitumumab, but used it in unselected patients and got the median survival up to 11.3 by bringing a targeted agent into the equation. And then there was this paradigm-changing study in gastric cancer called the TOGA trial, in which 4,000 patients were screened in order to find 580 patients who actually had HER2 positivity and could be randomized in the trial, because this was one of the first studies, at least in GI cancer, that used a molecular genetic selector to narrow the field to the patients most likely to respond to treatment. And here you see that it was either 5-FU or capecitabine plus cisplatin with or without trastuzumab. And the results were fairly dramatic. Here you see the tumor response rates, which were considerably higher, particularly the CR rate, which was more than doubled by the addition of panitumumab to chemotherapy. Here you see the difference in progression-free survival, 1.2 months, modest, but still pushing the bar. And for the first time ever in a gastric cancer study, the median survival for patients with advanced disease exceeded what seemed to be an iron ceiling of a year of median survival. And when the selection was refined even further with a retrospective analysis for those patients that highly expressed by IHC, the HER2 receptor, the median survival got up to 16 months. So at least in GI cancer, this was a paradigm-shifting study, a study that really took a molecular genetic marker and exploited it to the benefit of patients. And so what are the conclusions here? Using HER2 overexpression to select patients with gastric cancer for a targeted treatment was productive. It influenced in a positive way all of the endpoints. The higher the levels of expression, the better the outcomes, and that iron ceiling was shattered. So that suggests some promise. Now, those of you from UNC in the audience may or may not recognize Adam Bass, who is Joel Tepper's son-in-law, works at Dana-Farber, and was part of the TCGA and the lead author on the study in Nature that characterized gastric cancer. And we've seen a number of characterizations through the TCGA of various tumor types. In my mind, some of the findings in this study were surprising. There were 4 different subgroups identified. One that's EBV driven, which to me was not obvious before this analysis was done. And characterizations of this subgroup showed that there are potential leads of clinical relevance. These tumors, the EBV-related tumors, which are 10% of patients with gastric cancer, overexpress PD-L1 and PD-L2, leading to the potential of using PD-1 inhibitors as a therapeutic modality. Another surprising thing was that so many of these tumors were MSI high. So microsatellite instability, defect and mismatch repair is something that we've associated much more with colorectal cancer than we have with other cancers. But as we're unraveling the genome, we're finding that MSI high is an important driver in many different tumors. Then there was a genomically stable group of tumors and a group of tumors characterized by chromosomal instability. And while the TCGA had no clinical outcomes data, and that's the next step in helping to apply this information, it certainly helped us survey the landscape in a way that should lead us to therapeutic advances. Now, you see lots of these heat maps in each of the TCGA papers. In this particular one, I've pointed to the microsatellite instability as a large group of tumors with a characteristic outcome. If you look at the division here into EBV, that's a minority, about 10%, about 20% MSI, about 20% genomically stable, and then the remainder 50% chromosomal instability. And sorting this helps us understand it and hopefully unravel it further. And here you can see that in particular for the EBV mutation, or the EBV-driven group and the MSI-driven group, PIK3CA mutations are very common, and that gives us a sense that exploiting that pathway may be of therapeutic value. And here again you can see a number of other potential targets down here in the section B, EGFR, ERB, 2 and 3, JAK, FGFR, and MET that we need to explore in treating patients with these diseases. And then the other thing that was fascinating about this is the genomic differences correlated with differences in location in the stomach. And you can see that the little balls of showing the various concentrations within each anatomical area of the stomach correlated with the genomic changes as well. And so this is perhaps the interface between anatomical pathology and genomic pathology that we can again learn to exploit in a different way. So to finish up on gastric cancer, trastuzumab added significantly to chemotherapy in tumors that overexpress HER2. This genomic analysis helped us understand and subdivide gastric cancer into at least 4 molecular subtypes that correlates with location, and that this provides a platform for trials of targeted agents in subgroups selected by the genotype of their tumor. And what I like to tell patients about this when I ask them if they want to have their tumor genotyped is, as we get into later lines of therapy, what this allows us to do is to potentially take a shot in the light rather than a shot in the dark as we begin to look for phase 1 trials of targeted agents for those patients. So now I want to turn to the area where I do my research, genomics and colorectal cancer, and talk about cancer and the insights that we've gotten from that. You know, back in the early 1980s when I was a fellow at Georgetown, we thought about cancer in a different way. And in many ways, we thought about what I like to call the reservoir theory of cancer spread. And what I mean by that is you'd fill up one area with cancer before you'd spill over into the next area. And so if you look at it that way, the mucosa is the first reservoir. That's where the adenocarcinomas start. Then reservoir 2 is getting deeper into the layers of the colorectum. And then reservoir 3 is breaking through the 3 layers of the colorectum and dropping metastases around the area where the tumor originates. Then we get into regional disease with lymphatic spread into regional and distant nodes, and then into blood-borne metastases to the liver, bones, and brain. And those are the things, of course, that end up with a potentially curable patient not being curable, and us having to change our goals from the potential for cure to the best potential being to minimize suffering and extend life. And then there also is the issue of potential iatrogenic dissemination, as we've started to do laparoscopic procedures on patients. We find that sometimes we're seeding the biopsy tract or the port tract. And this was one of my mentors at Mayo, Len Gunderson, who's still very active in his retirement. Len was an anatomist before he became a radiation oncologist and has made some seminal observations about staging using the standard anatomical staging. And this particular study that he was the first author on and I was the senior author on, and that was an interesting thing to be the senior author for your senior mentor, was published in JCO and is a reference that's very commonly used to show the changes. And in some ways it shows that node negative tumors that are T4 that break through and attach to other organs are worse than those that are node positive, and this in some ways challenged our notion of the reservoir theory of cancer, because a lower stage tumor was actually a more lethal tumor. So the old notion was that tumors are uniform and they spread in an orderly way, and when you gave a chemotherapy drug or drugs to tumors, all the tumors were affected alike. And we've heard over the day yesterday about discordant responses from David Carbone, where lesions in the lung will shrink but two will grow, and the understanding now of that is in this cartoon, where you begin with a normal cell that then mutates, becomes a tumor cell, and then as time passes, multiple mutations occur within the daughter cells of that tumor that potentially make them have different sensitivities to the treatment that you're using. And that makes our job a challenge, because if we're trying to cure cancer, we have to, we believe, eliminate every last one of those cancer cells, and they're elusive targets because they're changing as we treat them. And here's just an example of tumor heterogeneity. And so this is a picture of ductal carcinoma in one section of breast cancer. Here's the same tumor in a different section looking very different. And then here's a third section of the same tumor, again looking very different, illustrating visually the point that I was trying to make on the last slide of tumor heterogeneity within a single lesion. Now, the seminal paper for the TCGA in colon cancer was published in Nature by senior author Raju Kucherlapati, and it really has been a starting point for a great deal of work that is continuing. And what was learned from these 276 colorectal cancers, again, these were tumors that were freshly obtained and studied in multiple ways, but their outcomes of these patients were not known. And so there was no way to know whether what you were finding had an effect on the outcome of the individuals. And that's something that we're going to be studying as a next step, and I'll talk about that study in a little bit. But what was discovered here is that 16% of patients were hypermutated. So actually fewer patients in colorectal cancer have tumors that are driven by mismatch repair defects than is true in gastric cancer. That was a surprise. One of the things that had been a source of argument among us was, are colon and rectal cancers different? And at least genomically, their fingerprints are the same. And so this was another important observation. And then there were 24 genes that were significantly mutated in high frequency. And most of these were not surprises. So APC and TP53 and PI3 kinase and KRAS. But there were some surprising genes, ERB2, IGF2, that we wouldn't have predicted could have an important role in driving colon cancer or an important potential for therapeutic outcomes. And so if you look here at the division, 16% were hypermutated, 84% non-hypermutated. Among those that were hypermutated, some had microsatellite instability, some did not. Within the microsatellite instability is the inherited microsatellite instability group of Lynch syndrome, but the larger group that are hypermethylated, and that is what inactivates the microsatellite pathway. And here you can see the hypermutated group as compared to the non-hypermutated group. You probably recognize MLH and MSH and POL as markers of defective mismatch repair. And here you can see that among the hypermutated tumors, there's quite a different profile of genomic abnormalities than the non-hypermutated. So APC is the most common finding in non-hypermutated, but the second most common. So 81% of non-hypermutated tumors had an APC mutation, while only 50% of hypermutated tumors. So really, this is a robust difference between these two subtypes. And I remind you that if you look under the microscope at colorectal cancer, what you tend to see is tumors that all look the same. They're all adenocarcinomas. They're almost all grade 2 and grade 3. The differences are hiding from the microscopist, but are visible to the geneticist. And here were the findings by pathway. So Wnt signaling was one important pathway, and Bob Coffey from Vanderbilt had described this and had been pounding the podium about the importance of Wnt signaling, but this bore out his findings. Then TGF-beta signaling is another important subset. PI3 kinase signaling, another important subset. RTK RAS signaling, another important subset, and then P53. So again, this gives us a framework to divide and to understand the heterogeneity of colorectal cancer in a way that hopefully we can exploit therapeutically. So it's interesting, Harold Varmus, NCI director, now NCI director emeritus, and Nobel Prize winner, said of the TCGF, while it may take years to translate this foundational genetic data on colorectal cancers into new therapeutic strategies and surveillance methods, this genetic information unquestionably will be the springboard for determining what will be useful clinically against colorectal cancers. And I think that that's true, but the limitations on it were that there was no outcome data. However, in some ways, this could be our Rosetta Stone that will help us read what colon cancers are trying to tell us in the future. Now, this is a study that was done by Sabine Tejpar as part of the European PETAC group, where outcomes were known in patients and where retrospective looks at the genome were done after the known outcome of the trial. And here again, you can see a heat map that segregates into 5 different stories. And if you look down here, these are outcomes that are different on the basis of which group the tumor segregates into. So it looks like genomic profiling can be predictive of outcomes in this setting, in the adjuvant setting here. And this is just a blow up of that heat map. So what were the 5 groups? Well, there have been a number of different studies that have done this. All have been able to divide colon cancer into some number of groups. Sometimes it's 3, sometimes it's 5. It doesn't really matter what they are here, but what does matter is that they were able to characterize subsets of tumors through this effort. So a study that I'm working on with Carmen Allegra and members of the NRG, as well as members of the Alliance, is this study called Genotyping of Tumors in Patients with Stage 2-3 Colon Cancer, Identifying Genomic Markers Associated with Recurrence and Poor Outcomes. So what we're doing is taking about 5,000 patients that some of you in the audience randomized into clinical trials, the N0147 study, which I wrote when I was at Mayo and then was subsequently conducted by Steve Alberts, FOLFOX plus or minus cetuximab, the COH study, FOLFOX plus or minus bevacizumab, and then the earlier generation study of 5-fluorouracil versus FLOX. And what we're going to do with these tumors is to do whole genome sequencing, RNA-seq, miRNA analysis, and potentially other analyses. What are the specific aims of this study? To characterize the role of germline and somatic genetic variability with respect to prognosis, mainly in stage 3 colorectal cancer. Characterize the role of baseline mRNA and miRNA profiles with respect to prognosis. Characterize the joint genomic profiles. We're looking at both somatic and germline genotypes with respect to prognosis. And then we also can use this for pharmacogenomic analysis to look at the potential toxicities of the treatments that we're using. And of course, those of you who listened to the State of the Union address heard our president tell us that he was putting $215 million toward cancer genomics, and Dr. Varmus, before he left, said it didn't matter whether Congress funded this, he was going to apportion $70 million to this regardless. Well, it's an interesting story. I didn't have to apply for the grant that's going to fund the research that I talked to you about. We just got a note from Dr. Varmus saying, we'd like to give you $3 million. And so that was like getting the Pinedo Prize. It was money that showed up in an envelope that I didn't have to compete for, which is a great thing. Applying genomics to colorectal cancer management. So again, as I mentioned to you, 15 or 16% of tumors are due to defects in mismatch repair, the spell check of DNA. 85% are due to chromosomal instability, Lynch syndrome 2 to 3%, acquired defective mismatch repair about 13%, and then almost all of the tumors that arise through the chromosomal instability pathway are sporadic, which means they don't have an inherited genetic basis, but are an interaction between genetics and environment. And I'm going to focus first on microsatellite instability. There has been some data that we have helped to unravel about the effect of microsatellite instability in 5-FU, which is, of course, the most common drug that we use in colorectal cancer. And then some additional interesting information about another drug class that you can use as a potential intervention in colon cancer, believe it or not, aspirin or NSAIDs. And so an intervention with potentially a lot less toxicity than those that we're used to using. This is my friend and collaborator, Dan Sargent. We had done a number of studies over the years looking at deficient mismatch repair as a predictive marker for lack of benefit from 5-FU. Here you can see the potential basic science background about this. And if you look at HCT116 colorectal cells in cell culture, these are 5-FU resistant, but sensitive to Arenotican and oxaliplatin. So that helps to explain the clinical finding that's been observed that 5-FU is not helpful in these patients, but if you add in the other chemotherapy agents, you can get response. And I'll give you a few more details about that over time. So here's some data looking at patients who are randomized to clinical trials with stage 2 colon cancer, segregated on the basis of proficient versus deficient mismatch repair. And if you look at the overall survival in this study, they were the same, regardless of whether patients had proficient or deficient mismatch repair. But the fascinating thing is that if you looked at the untreated patients, those who had proficient mismatch repair actually did considerably worse, 5-year survival of 56% versus 80%, than those who had deficient mismatch repair. So having deficient mismatch repair was a positive prognostic factor in these patients. Now the question was it predictive of value from 5-FU? And here you see that untreated patients with a defective mismatch repair in the blue line did far better than treated patients. So this is fascinating. We're using a chemotherapy treatment that we believe is helping patients, and it's actually hurting them. One would wonder, well, how could that be possible? And it's interesting, when you ask pathologists like Tom Smirk, who was Henry Lynch's pathologist at Creighton for many years and then went to Mayo, if they think a tumor has defective mismatch repair or not, they can tell you often by looking at it under the microscope, because Lynch syndrome tumors have heavy infiltration of tumor-infiltrating lymphocytes. And the theory is that maybe what we're doing is we're killing the wrong cells. Those tumor-infiltrating lymphocytes are what is containing the tumor, and the 5-FU is getting rid of them. And I have to tell you that this week in clinic, I saw a 26-year-old with Lynch syndrome with widely metastatic colon cancer who's on a PD-1 inhibitor. And it's the first time in my career I've ever seen the Lazarus effect. This woman went from coming in a wheelchair, barely able to sit up on a table, to after 2 weeks on the PD-1 inhibitor, going back to dancing. And the nodes in her neck disappeared, and the breast mass that she had disappeared. And I believe it's because we have figured out how to exploit immunology in the management of Lynch syndrome. And this is somebody who had gotten heavily pretreated with chemotherapy that we use, and to which she'd had no response. So there's a lot there to understand. Now, it is true that MSI as a marker of prognosis seems to be a robust marker, that those patients who have MSI high tumors do better than those patients whose tumors originate from the chromosomal instability pathway. Now, the story may even be a little bit more complicated than that. Here's some work by Frank Sinecrope, one of my collaborators at Mayo, looking at proficient versus deficient mismatch repair. Over here, it's percent of recurrence. Those with proficient mismatch repair recur more commonly than those with a deficient mismatch repair. But one of the things that he looked at was to separate patients as to the origin of their mismatch repair. Here are the Lynch patients who seem to benefit from 5-FU-based therapy. Here are the hypermutated patients who seem not to benefit from 5-FU-based adjuvant therapy. And so there's still more to unravel in this story. And then finally, here's a study that we did in CLGB before it became the alliance with Monica Bertinoli, looking at whether microsatellite instability can predict sensitivity to Arenotican-based regimens. This study was negative with respect to the value of Arenotican versus just 5-FU leucovorin in treatment of colorectal cancer. There were about 1,200 patients. We did an analysis looking at those patients who had deficient mismatch repair. Here you see the disease-free survival, which shows no difference. But if you just look at those patients treated with Arenotican, who were treated with the Arenotican arm of the study, there was a trend toward a better outcome, suggesting that Arenotican has a differential effect in patients whose tumors originate through the mismatch repair pathway. So the conclusions: deficient mismatch repair is a prognostic marker, generally a better marker of outcome. There's no suggestion of benefit from 5-FU-based treatment in deficient mismatch repair patients. There may be a difference between Lynch and hypermethylated tumors, and that there's a significant overall survival decrement to 5-FU-based therapy, at least in stage 2 patients. So what do we do about this clinically? Well, at Ohio State, we are now genotyping all of our patients with colon cancer. And that's regardless of whether they're young or old. In the past, we only looked for Lynch syndrome in young patients. We know that MSI status is both prognostic and predictive. We don't give patients single-agent 5-FU if they have mismatch repair high tumors. Their prognosis is usually so good in stage 2 that we don't do anything for those patients but observe them. And if those patients have stage 3 disease, you would use FOLFOX as a standard of care. That can be important in older patients because hypermethylation as a cause of mismatch repair is much more common in older patients, and some people would just consider treating those patients with single agent 5-FU. That's probably not a good idea. Now, these are collaborators also from Harvard, Charlie Fuchs and Shuji Ogino, who have looked at the PI3 kinase signaling and the use of aspirin as a potential mediator for treatment of colorectal cancer. And you can see that aspirin can have multiple potential effects, or other nonsteroidals as well, on blood vessels and platelets, on inflammatory cells and stromal cells, as well as on those pathways that are known to be deranged in malignancies, including the PI3 kinase and AKT pathways. And what they did was at first look at, in, again, one of our retrospective analyses of a CLGB study, whether or not PI3 kinase mutations, which occur in 10 to 15% of colorectal cancers, are prognostic or predictive of standard chemotherapy outcomes, and they're not. But then they looked in the Women's Health Study at individuals who did or did not use aspirin and their colon cancer specific mortality based on PI3 kinase mutation or lack of PI3 kinase mutation. And you can see here that for those who had wild type PI3 kinase cancers, that aspirin was of no benefit, but those who had a PI3 kinase mutation actually benefited from a simple intervention, which is using aspirin. When you have a BRAF mutation, which occurs in 10 to 15% of cases, it constitutively activates the RAF-MAP kinase pathway, which activates prostaglandin synthesis. And in this circumstance, regular aspirin use was associated with a significantly lower risk of having a BRAF wild-type tumor. So it does seem to benefit patients with mutant PI3 kinase, and to be preventive of BRAF wild-type tumors, and there appears to be a benefit in tumors that overexpress COX-2. So again, in my clinic, I recommend aspirin to patients who've had a stage 2 or a stage 3 colon cancer, who've been treated curatively, as long as they don't have a contraindication. And for those stage 2 patients who I'm telling they don't need chemotherapy, I generally recommend aspirin to all of them, along with exercise and vitamin D and calcium. Now, there was some talk yesterday about gene expression platforms, and this is something that has been looked at in colorectal cancer by a number of different companies. You can see here that Genomic Health, Almac, Agendia, and DiagnoCure all have platforms. The best developed platform is the Genomic Health Oncotype DX, which looks at 12 genes. Here's the initial study done by David Kerr and his colleagues using the Quasar adjuvant trials to try and validate this. You can see also a study done by NSIBP looking at this particular 12 gene array. And the bottom line was that in stage 2 colon cancer patients, using these stromal and cell cycle genes and these reference genes, in stage 2 patients, you could differentiate between patients who had a 9% likelihood of recurrence versus those who had about a 28% likelihood of recurrence based on where they fell using a complicated algorithm that weighted each of these genes differently. And this is of some utility in the clinic. It's not as useful as what's done in breast cancer, because in that circumstance, not only is this predictive of prognostic, but it's also predictive. In colon cancer, it is prognostic but not predictive. And so here you can see that when you add stage to and mismatch repair status to the 12 gene recurrence score, you can further differentiate outcomes in stage 2 patients. So what were the questions answered by these studies? Is there a prognostic gene signature? Yes. Is the signature predictive? No. Are there other platforms out there? Yes, there are at least 2 others. one of the questions it raised is the difference between 11 and 22% sufficient to order the test? And I have to say that I order it, but rarely. Can we find better signatures? Yes, but at least this is breaking new ground. Now, I want to talk briefly about Rash mutation as a marker for drug resistance. This is a study done mainly in Europe, reported by Jean-Yves Dillard, looking at FOLFOX plus or minus panitumumab for first-line therapy. Here you can see hazard ratios for progression or death according to KRAS wild type versus KRAS mutation. And you can see that for non-mutated KRAS, there was a benefit for treatment. For mutated KRAS, there actually was a decrement when you use panitumumab with chemotherapy. And so this is a genomic finding that we use every day in clinic. We never give patients with any RAS mutation, any monoclonal antibody targeting the EGFR receptor. Now, what about BRAF mutation? This is also something that we're finding is of utility in this circumstance, and here you see significant differences with respect to outcome on the basis of BRAF mutation as well. Other potential predictive markers, SMAD4, that was one of the abnormalities in the TGF-beta pathway that was identified by the Cancer Genome Atlas analysis, as well as these three markers that are in the EGFR pathway. Are these predictive? You can see here that there is a significant difference in overall survival on the basis of whether these genes are mutated or not. So how do I use this in clinical practice? Well, at OSU, we're testing all metastatic disease patients for RAS, pan-RAS testing, as well as BRAF mutations. And we use no EGFR targeted monoclonal antibodies if we find that. We aren't testing for EGCN or PI3 kinase or PTEN yet, but that may come in time. One of the other targeted agents that we use, bevacizumab or aflibercept, which targets vascular endothelial growth factor receptor, has had no marker discovered, and we would very much like to find a marker for efficacy or resistance to those agents, but that has so far been elusive. Now, how do we develop biomarker-driven randomized trials? And here are several pathways. One is to evaluate the biomarker. If the biomarker is positive, you randomize patients between a new treatment and a standard treatment, the new treatment being targeted toward that biomarker. And this study was actually mentioned by Peter O'Dwyer yesterday. It's an active study in SWOG, cetuximab plus Arenotican versus vemurafenib plus cetuximab for patients with BRAF mutant tumors because vemurafenib targets BRAF, and that study's in progress. Here's another way of designing these where the biomarker negative patients are also randomized to a standard versus new treatment, and we're beginning to see these treatments come into play. This is a very important study that's being done in the UK called the FOCUS-4 study, an integrated trial program of parallel, molecularly stratified, randomized comparisons for patients with advanced cancer. That's considered a window of opportunity study. And so here you can see that these patients are all genotyped. We look for, or they look for, BRAF mutation, PI3 kinase, or PTEN loss, RAS mutation, all wild type or non-stratified. And the patients are randomized to different agents on the basis of their molecular genomics. And so as we interpret these, we are more and more commonly ordering Foundation Medicine tests or your favorite test and getting reports, and I would say that standard physicians, particularly people of my generation, have varying ability to interpret these. And that's why it's great to have somebody at OSU like Samik Rajchowdhury, who's going to talk to us later, who hosts a precision medicine tumor board and helps us understand what are actionable mutations versus mutations of unknown value, and helps us to take that shot in the light rather than that shot in the dark. So currently we have clinical validation mutation testing that are prognostic and predictive, ones that we use every day in clinical practice in colorectal cancer are RAS and BRAF. We have mutations of potential significance that currently are investigational, but at least we have identified them for further research. We're beginning to do novel and adaptive clinical trial designs that allow biomarker enrichment, like that whole TOGA story I told you with the HER2 and gastric cancer at the beginning of the talk. With the ability of mass sequencing technologies, we can now characterize individual tumors and the individual's genome to compare the differences and help to sort out what are the driving mutations for tumors. Our available genomic knowledge is ahead of our ability to therapeutically target the tumors, but we are now able to offer people genomic-driven clinical trials, and certainly OSU is making a big investment in that, as you'll hear as the morning goes on. And clinicians' genomic confidence is variable, so we need to educate physicians about how best to interpret this. So I'd like to thank you for your attention. I'm 13 seconds over, but that's not bad. And I'd be happy to answer any questions.
Rich, great talk. I noticed on your list of mutations for colorectal cancer, ARID1A. Mm-hmm. Well, that was mentioned yesterday in clear cell ovarian cancer as a commonly mutated gene. And it turns out that that's a regulator of histone methyltransferase. One of the histone methyltransferases, EZH2, and there are drugs now in the clinic for EZH2, so it is actionable potentially.
Right.
It would be very interesting actually to look at cell lines with this mutation and colorectal cancer to see if they're sensitive to EZH2 inhibition.
Absolutely. It's interesting. I just got asked to chair a session at ASCO, which is talking about does the organ where the tumor originated matter, or should we be running studies that are based on the genomic abnormalities instead of the organ of origin? And for example, we're doing that in a study we're doing with Hopkins, looking at a PD-1 inhibitor where anybody with an MSI high tumor can go on. And so we have a patient with prostate cancer on the study, a patient with gastric cancer, as well as colorectal cancers. Yes, hi.
Rich, with your microsatellite instability, so you're checking these patients routinely. So do you have concerns you're going to give them FOLFOX, so they're still going to get FU, right? So
right.
Do you have concerns that may be a counterproductive combination here? And are you interested in, are you doing any little phase 2 randomized, to see if maybe they should not have 5-FU? And then what do drugs like oxaliplatin and others do to lymphocytes infiltrating tumors? Do we know? So
we don't really know what they do to lymphocyte infiltrating tumors. Oxaliplatin by itself has no activity, and so it has to be with 5-FU. And the data does show that when you in MSI high cells grown in culture, that FOLFOX is active even when 5-FU is not.